Good afternoon. I'm Katherine Littler. I'm one of the 3 people that worked on the framework on health-related findings in research. I worked together with my colleague Beth Thompson at the Trust and Catherine Elliott at the Medical Research Council. Thank you very much for the opportunity to talk about this. Adrian specifically asked me to give a brief talk on this, basically outlining the background, how we came to come up with the framework, the history of it, and then what the framework entails. So hopefully I will keep it brief and understandable, given my sleep deprivation. So I'm going to start with the background to the project. So basically the mandate, why we started this project, it wasn't from us as policy people, it was actually a mandate that came from the research community back in 2008, which seems quite a long time to develop a framework looking back on it now. We had a Frontiers meeting here at the Trust on genome-wide association studies, and 4 major issues came out of that. And one of them was the feedback and the difficulty that the genetics community at that stage was having dealing with feedback. At the same time, in the summer of 2008, a special issue of the Journal of Law, Medicine and Ethics had a whole series on incidental findings. And then we took a paper to the Wellcome Trust Board of Governors, a workshop, to explore these issues further in May 2009, and they gave us a mandate to continue with this work and to go out to the research community and find out if there was a need for a policy or a framework or what the research community wanted from us. So the next stage, we divided it up into multiple stages, and the first thing we did was we commissioned a literature review looking at the legal and ethical implications of incidental findings. The main things that came out of that were, at that stage, specifically in the UK, which is where we looked at primarily for the legal status, we found that at that stage there had been no case law and there was very little coherence or understanding as to what the legal position was in relation to a duty of care to report back research findings. Specifically at this stage we were looking at incidental, but I will talk more about the fact we've widened the definition. And in terms of the ethical, we looked at the harms and benefits at that stage and noticed that there was a lack of an evidence base as to the harms and benefits of returning research findings. The next stage we undertook over a 2-year period was a policy analysis, and that is we basically looked at different studies policies across the States, across Europe and in the UK. What we found was an absence of policies for the majority of studies. Some studies, like the UK 10K at that stage, were exploring a policy and had a policy. Some big studies like ALSPAC had policies, but overall, most studies at that stage didn't have a policy and were struggling at how to come up with a policy for this, or they hadn't even thought they needed a policy. So the next stage further on from that, it's also important to say at that stage we also noticed that some principles were forming, i.e. the principle that you should return research findings if the condition's serious and treatable. So that was a principle that was emerging, but other than that there wasn't a lot of principles emerging, there weren't a lot. The next was assessing the time and costs of implications of feedback. So we hired some consultants to look into the cost implications. And that was very, very hard to do because we didn't have very specific models. They came back from anything from £40 to returning a imaging analysis after a radiologist has looked at, to £400 to £500 looking at different types of genetic analysis. From that, we actually got together 2 stakeholder workshops, one in September 2010 and one in June 2011. These were primarily with the research community, with a cross-section of genetics, genomics people, radiologists and other people who are conducting and cohort studies, and got them together to find out if they needed a policy, what was going on in their relevant communities. The main findings coming out of that was that there was indeed a mandate from the community. They did want us to look further into research, into developing this policy. At that stage, the Royal College of Radiologists hadn't developed their policy. They have since done that in the UK. But there weren't that many policies existing. There was definitely no guidance across the UK. In the US, it was starting to emerge. So we took from that what we were told then. I mean, for starters, when we went to the genetics people, we said, what about giving a list of 50 genes that you could return? And most people didn't like that. I understand they've done that in the States, but the genetics community here in the UK didn't support that proposition. So we were quite surprised at how little people were doing the same kinds of work in the same policies, the same procedures in the same area of research. We had engaged largely at that stage and that point with the research community and realised we had a big hole in our analysis, and that is we hadn't done any public or participants' attitude work at all. So we then commissioned Opinion Leader here in the UK to do some public attitudes work. They did some quantitative and some qualitative research. They did a survey of over 1,000 people on the internet asking a variety of questions. And then they also did 8 focus groups. The focus groups had members of the general public, they had people who had participated in research trials, and people whose families had participated in research studies. What came out of the public's attitude research was an overwhelming desire by the public to have their research findings, individual level research findings, returned to them, and for them to be able to say when they wanted them returned. So they wanted to join a study and to be able to say whether they could or couldn't have their research findings returned. The other thing that came out was that there was very little understanding by members of the general public on the whole research process and how it worked. They didn't understand the beginning, what's the difference between a clinical trial in some ways and other types of research that's conducted. The other thing that came out of this research was that it's critically important that people understand from the consent what's going in relation to health-related findings. They wanted to know then and it be explained clearly and transparently. And the other main thing is, the nuance in all this is they didn't want all their research results. Most of the research results that they wanted were the things that were serious and treatable. And even when we offered in the focus groups or offered, explaining that there could be some harms with some of the research findings that you'll get back, people still wanted that information back. So that's the findings, that's the majority of the work we did. We also obviously consulted again with the research community once we had done it. We then launched this policy, the Wellcome Trust, together with the MRC and support from the Health Research Authority in March 2014 with a commentary in The Lancet. At that stage, we also got the support of, I think, 5 other UK-based funders, but it's important to say that this policy applies not just in the UK, but it applies for all human subject research that both the Wellcome Trust and the MRC fund, so no matter where it takes place. So we had to, in drawing up this policy, make something that was fit internationally, but at the same time couldn't be a one-size-fits-all model, because that's what came out, that the community didn't want that. So we worked out after 4 years or 3 years of doing all this that we couldn't be overly prescriptive. And what the community really wanted from us was something in which they could work out how to formulate a policy. So we came to the conclusion that everybody should have a policy. What they put in that policy at the end of the day is down to them, as long as they can justify it. And that's also what the public wants. The public wants confidence in the research process and to be able to understand why a policy has been made. So from that, we came up with the following framework to help guide it. So it covers incidental findings, and we use the definition that Susan Wolfe did in the Journal of Law and Medical Ethics, which you can all see up there. We also include in our definition of health-related findings pertinent findings that relate to the aims of the study. As I said earlier, it applies to all types of human subject research that we fund. It's findings from known clinical significance or relevance, not new research observations, and it's individual, not aggravated findings it applies to. So what are the expectations of this? I'm going to go through it in a second, but what are the expectations of this for the researchers? Well, as I said, it's to have a policy, which might sound like a no-brainer, but for lots of studies, they hadn't had a policy and they hadn't thought about it. The big study is much easier to do, and they need to be able to clearly justify it, not just to us as research funders, research ethics committees, but particularly to participants. They need clear information on the study policy and the feedback in the consent process. As I said, when we did the public attitudes research, that was critical, that the information needs to be delivered at the point of consent. In cases where the policy is to provide feedback, they need to develop a robust, practical feedback pathway. One other thing that came out of the public attitudes research is people wanted to have clinical people involved in the feedback mechanism, whether that be a doctor, a radiologist, or a specialist, or whatever, or a geneticist. They wanted to have some sort of clinical or medical person involved. So, not the world's greatest slide, so apologies in advance, but the middle slide, the one where it says 1, is basically the categories that we put that people have to, in the framework, that they have to consider in developing a policy. So the nature of the the research findings is pretty self-explanatory. What type of finding is it? What's the probability of it being returned? What's the probability of false positives? Look at that and consider that. What is in the best interest of participants? Now, this to a lot of people seems like a very straightforward one. But as I said earlier, there is a lack of evidence base on what is actually beneficial and what is harmful. There are obviously some no-brainer, barn door, obvious cases where there is going to be benefit to the participant, but they are not the majority of cases. They are probably in the minority. So looking at if you can find an evidence base, using that to justify your policy. Good practice, is there established good practice? I said the Royal College of Radiologists has developed guidelines, so you would expect to look at those guidelines in developing your policy. If you're a cohort study, you'd expect to look to see what other cohort studies are doing. What is the study context? Now, this is important in the sense that I said that this is an international policy. So giving feedback in a scenario in a country where they might not be able to act on it could be considered unethical in itself. So is there a healthcare setting in place that can deliver on actually treating what you've come up with as the serious or treatable finding, or whatever it is? So that's a very critical question to consider. The practical implications. Cost is an implication that does need to be factored in. If you are returning feedback on a large scale, you might not be able to conduct some of the research that you have originally set out to do. So is it right to ask the participants, what would you like? Would you like us to do more research, or would you like the feedback? I think that's something that needs to... So cost needs to be factored in. Feasibility, is it feasible to actually be able to give it back? How is your study set up? And then the nature of the existing consent. So what I mean by that, so the policy doesn't apply to studies at the time that that had already been set up, but it does apply if they are reconsenting for future research within that study. So looking at the nature of the existing consent is also important. So we have an arrow going no and an arrow going yes. So that is, the arrow going to the no is if you decide not to feedback, then this is what you should be considering as a researcher. You should inform the patients why that you have not fed back in the consent process, and you should be prepared to explain to the participants why that you haven't. And then the other side is obviously yes, if you have decided to develop a feedback policy. So that's the scope of the feedback. What are you actually feeding back? That sounds quite simple, but you have to explain that if you say that you're going to feed back a serious, potentially treatable, you need to explain what that actually is and what that means in clear layman's terms so people understand. Who's going to be involved? How is the feedback going to be given? And importantly, do the participants have a choice? Because it is possible to set up a study where they can only participate if they get feedback, or they can only participate if they're not. And then the third little bullet there is looking at the actual pathway. If you are setting up a feedback pathway, how and when are you going to identify it? Do you need to verify it? Does it need clinical verification, given a lot of these studies are just in the research context? And how is this going to be fed back? What's the time frame? Who's involved? All those things need to be factored in. And finally, as I said, I'd be brief, just some comments on UK Biobank and the framework. So it didn't apply to Biobank in the sense that it already had consented to 500,000 people. But as we know, Biobank's an ongoing study that will be doing enhancements throughout the course of the study. So it will be reconsenting participants constantly for follow-on research. So Biobank has to readdress this issue. And in doing so, look at its existing consent as a consideration, but it can't just rest on the existing consent, because our policy said that's not the way to do it. And times will change, and people's attitudes. What they consented to in 2007 might not be what is the prevailing ethos or what they would agree to in 2020 or 2030. Feasibility and costs, as I said before, it is a study of 500,000. Reconsenting is a costly process, so how would you do it? If you're only going to if they're doing enhancements that are only 25,000 people, how do you set that up when 25,000 people over 500,000 study have a different consent on feedback to the others? So how are you doing that with when the secondary researcher comes to the repository and asks, how do you set this up in such a manner that you can actually give that feedback back? And then, I think most importantly, what's happening at the moment with the imaging pilot study, so Biobank's conducting an imaging pilot. I think they've just had their 1,000th person go through it. What they're also doing at the same time, and is critically important as far as funders are concerned, is building the evidence base as to potential harms and benefits. So I said earlier that there is a lack of evidence. They are conducting some social science research. They are looking into the harms and benefits, the rates of false positives, all those things, and that will be conducted over the next year. So it will be great to see that evidence base. And that's all I have to say. Thank you.